how are brain mets typically diagnosed?
Right now, the most common way that brain mets are diagnosed is if a patient reports symptoms, and then that prompts usually an MRI scan of the brain to look to see why those symptoms appeared. And a lot of people worry, a lot of people ask me questions about whether memory loss or forgetting where the keys are, are a sign of brain metastases. And it's a common question because it's a common occurrence. But that's not the way brain metastases usually present. So the most common symptom is headaches. And if we see headaches that are associated with nausea, and let's suppose somebody's on their 7th cycle of the same chemotherapy and all of a sudden they're nauseated, that's not right. If somebody wasn't nauseated for the first 6 cycles, they shouldn't really be nauseated for the 7th cycle. And that really raises a red flag, especially if their headache's associated. Or sometimes people notice that their coordination or their balance is off, or they've had a fall, and there's no reason that a 34-year-old woman should, trip off the curb for no reason. It really raises the red flag. Is there some underlying issue that is need for concern? So I have a very low threshold to image the brain in somebody who has metastatic breast cancer. And any of those symptoms, headaches, incoordination, balance problems, etc., certainly any weakness on one side versus the other, and also seizures, which are not so common, but any of those kinds of symptoms should prompt a brain MRI.
You mentioned seizures. How do you know specifically? Because that's, in the community that I talk to who have brain metastasis, that is certainly a really big worry for them. Do you know approximately? You say they're not very common.
Yeah,
What the
so
is?
when people have looked to see, of the symptoms that were the first symptom of a brain metastasis, about 10% of the time, around 10 to 15% of the time, depending on which study you look at, is seizure the first symptom. So it's not rare, but it's not the most common, whereas around 70% of people have headaches.
So as far as medication for seizures, it's not something you would put a patient on prophylactically. You would wait for them to have an actual seizure.
That's exactly right. So, it's quite reflexive to think that, when you have a patient who has a new brain met on a scan, to immediately put them on an anti-seizure medicine. It feels like the right thing to do, but there actually have been clinical trials, randomized clinical trials, showing that there isn't a benefit conferred with that approach. And so the national guidelines, if somebody has not ever had a seizure, at least for breast cancer brain metastasis, is not to routinely give anti-seizure medicines. There are always exceptions to the rule, and certainly if somebody is going to the operating room and there's going to be potentially bleeding, oftentimes the surgeons will temporarily put people on a brief course of anti-seizure medicines. Similarly with certain types of radiation, it's not uncommon if there's a concern for a larger lesion to put somebody temporarily, but in terms of long-term indefinite use of anti-seizure medicines, we try to stay away from it except for patients who have had seizures.
Okay, that makes sense. So for screening or for diagnosis, you said it seems like it's symptom dependent. There's no guidelines for regular screening, even in those who are more likely to develop brain metastasis. Whereas when you have metastatic disease, there is the schedule for screening. Can you explain a little bit about why that is? And
Yeah, this is a really important topic, and I think it's a topic that we just as a community have not addressed in terms of clinical data or clinical trials as well as we could have. We're trying to do it now. There are actually some trials now, prospective trials, trying to develop evidence to see whether there are benefits to screening. But right now, there's no prospective clinical trial evidence to prove a benefit. And there's sort of conflicting evidence if you look backwards in time. So if you look backwards in time, you say, of patients who have brain metastases, could we have made a difference if we did screening? on the one hand, there's data that Dr. Eyal Azer, who is one of the radiation oncologists that I work with, that he generated, where he compared people at our institution who have lung cancer brain mets versus those with breast cancer brain mets. And the difference is for lung cancer patients, they usually get screened. And what he found is that in patients with lung cancer, their mets are usually diagnosed when they have fewer brain mets on average. The brain mets are a little bit smaller on average. They tend to need less whole brain radiation. So those are all really good things. And that is, in fact, what led to the trial that he's currently running. But there have been other groups that have looked backwards in time to say, well, of people who had brain mets found because they had a required brain MRI as part of a clinical trial, for example, some other reason they had a brain MRI where they didn't have any symptoms. And they looked to see, like, is the survival longer in people who had brain mets found by screening versus those with brain mets found when they had symptoms? And those studies have shown no difference in survival. So that's why there's this debate. And if you go backwards in time in medical records, you can't ask about quality of life and you can't ask about neurological symptoms or cognitive symptoms because you can't do that retrospectively back in time. And so that's the problem right now. It's really like a data problem. And so hopefully, there are 3 trials now going on across the world to try to look at the role of screening MRI, because right now we say we don't do it, and I don't usually do it because there's no data, but it's not that there's data that it's not good, it's that there's no data, or no prospective data. So, I hope that not so long from now we will have data and we can actually make a data-driven recommendation.
Yeah, that would be for optimal for sure to have something that guides us rather than making a decision on the lack of data, which
Yes,
is sort of challenging.
I agree.
So I assume there are risk factors for getting brain metastasis. Can you speak to that a little bit?
Right. So tumor subtype is one of the risk factors. So if you're triple negative, which is estrogen, progesterone, and HER2 negative, or HER2 positive, and I'm throwing out all these like jargon for subtypes, and I just want to, preface by saying, if you don't know what subtype you are, like, you should ask your doctor and find out, because everything in metastatic breast cancer treatment depends on the subtype, and it's something that it's a good thing to sort of know for your own care. But the other types of risk factors are things like being young. So young age does seem to increase the risk of brain mets. Having metastasis in the lungs seems to increase the risk of brain mets, and also having inflammatory breast cancer. So there are some of those risk factors. And then finally, for a specific type of cancer in the brain, what I talked about, which was this leptomeningeal disease, cancer in the spinal fluid, lobular breast cancer, which is a type of appearance under the microscope, seems to be more likely to do this.